Welcome to cardiac dysfunction. This is for chapter 23, and we're going to be going over cardiac dysfunction for pediatric patients. When we're taking the health history, we need to do a really in-depth investigation. We know that a lot of these congenital heart defects have a family history of them. We know that prenatal history, such as medications during pregnancy, if mother had an infection during pregnancy, and overall prenatal care can really affect that heart's development. We know that birth history can impact. We want to assess what's our feeding like. Do we have any developmental concerns? Are kiddos falling behind on their growth? Are they falling behind on their development? Are they not meeting their milestones? And overall, with all of these disorders, we really want to make sure that we're practicing atraumatic care by reducing our stress and anxiety of our child. So reduce separation from parent, cluster care when possible, because we just want to reduce that workload on the heart. So when you're doing your head to toe assessment, we always want to start with our inspection. And our inspection is looking at, what's the kiddo's color? Are our upper extremities the same color as our lower extremities? Is our core different than our periphery? What's our activity level like? Do we have a child who's really just laying around, not doing much, or are they able, excuse me, to maintain normal activities? Chest wall. Do we have normal chest wall? Do we see our point of maximum impulse? Are we symmetrical? Are we convex, concave? Are there scars? All of those are good indicators. And then being that so much of our respiratory is integrated with our cardiac, we need to know what's our respiratory pattern looking like. When we're auscultating, we use our bell for our low pitch sounds and our diaphragm for our high pitch. Our heart sounds should be synchronous, meaning happening at the same time as our pulses are. So when we're talking about comparing central pulses to peripheral pulses, our central pulses would be our point of maximum impulse, our point our PMI, and then our femoral and carotids are central, and peripherals would be your brachial, radial, popliteal, posttibial, or dorsal pietis. We should be listening for S1 and S2. Do we have any extra sounds? Do we have any murmurs? Those would all be things that we would be assessing. And then palpation. So when we're touching them, we want to compare upper extremities to lower extremities. How is that PMI? What's their blood pressure in all of their extremities? Pulse ox, just a non-invasive way to really note if we're having perfusion, right? Because if the heart is pumping the blood is carrying the oxygen. So if we have poor perfusion, our pulse ox is going to read low. Monitoring cardiac output. So cardiac output is the amount of blood that the heart pumps in 1 minute. The formula for it is our heart rate times our stroke volume. In infants and young children, the heart rate is the main driver of cardiac output. Stroke volume, so how much blood per beat, does not change much because their ventricles are small and less compliant. So if the heart rate drops, the cardiac output will fall quickly. Normal heart ranges in children, our infants beat faster, our adolescents are closer to adults. You'd have to look at your textbook to know what your heart ranges should be. The textbook that we use, infants are 100 to 160, toddlers are 90 to 140, school-age children are 75 to 120, and adolescents are 60 to 100. So all this matters because kids cannot increase stroke volume well. They rely on their heart rate. If a child is bradycardic, it is a late sign of dangerous issues, poor perfusion, and possibly impending cardiac arrest. Nurses really need to monitor heart rate close to judge that cardiac output. Signs of a low cardiac output might be poor feeding, sweating when feeding, tachypnea, retractions, frequent infections, poor weight gain, failure to thrive, pale mottled skin, delayed capillary refill, lethargy, irritability, or fatigue with activity. So these are just some common diagnostic tests for cardiac disorders. They're pretty much the same as in the adult world. Cardiac catheterization is considered a golden standard for diagnosis of congenital heart disorders. The patient or parent should be educated about, post-catheterization care, what their home care is going to be. Dressings can usually be removed after 24 hours, and then we keep them covered for a bandage. We have to keep the site clean and dry. Showers are okay, but no baths or swimming for about a week. Patients should avoid strenuous activity for about a week, and we need to teach patients when to contact a healthcare provider, such as if they're having fever, bleeding, chest pains, or sign of an infection. Another thing that should be noted here is that in children, when we're doing a cardiac catheterization, we're always going to be accessing or typically accessing that femoral. And if a child has a really bad diaper rash, they're not going to want to conduct the cardiac catheterization because the risk of um, going through that diaper rash, which is going to be like a fungal infection or maybe a staph infection, and introducing that into the child's bloodstream. So a really bad diaper rash would be a reason that they would delay that. Now we're going to go into rhythm disturbances. So in an older child, we might have them tell us about palpitations, dizziness, syncope, and exercise intolerance. In a smaller baby, they're not going to be able to tell you that they have those things, so we might just have some increased irritability. When we're talking about tachydysrhythmias, these are things that make the heart beat fast. And when it's beating super fast, it cannot fill. So with that, our output drops. Babies show this by not eating, by being cranky. They might be pale and they might have reduced urine output. Just because if we're having a drop in cardiac output, we usually don't perfuse the kidneys as well. So we have that drop in urine output. We want to always confirm with an EKG. Tachydysrhythmias, again, this is an abnormally fast heart rate. The definition is greater than 100, but we also need to take considerations that child's heart rates standardly can be above 100. So in a child, it would truly be greater than what their normal rate should be. In most children, the most common tachydysrhythmia is going to be SVT. And with that, an infant can have a heart rate of 180 to 300 in SVT. And in an older child, it can be 150 to 220. It often has a sudden onset and it can have a very abrupt stop. With this, we want to think about our clinical manifestations are going to be things that are going to support poor cardiac output. So we're looking at poor feedings. An infant might tire quickly with bottle feedings or breastfeeding. They might be really irritable and difficult to console. They might have lethargy and decreased responsiveness. We're going to have pale, cool, mottled skin, weak pulses, thready pulses, delayed capillary refill, poor peripheral perfusion, reduced output due to that low renal perfusion, and even signs of congestive heart failure like tachypnea, hepatomegaly, and edema. Why this is dangerous? The rapid rate means that the ventricles do not have enough time to fill. We're going to have a drop in our stroke volume. We're going to have a drop in our cardiac output, and we're going to have poor perfusion. Diagnosis, we need to capture it on an EKG to confirm the rhythm. Because episodes can be intermittent, occasionally we'll send a child home with a 24-hour Holter monitor or even longer to catch it. Brady dysrhythmias. In children, bradycardia is almost always bad. It usually means the heart is not getting enough oxygen and is about to give out. We always treat hypoxia first and confirm with an EKG. Brady dysrhythmias is that abnormally slow heart rate. So it's going to be a rate less than 60 beats per minute in a child and less than 100 in an infant. The rhythm may be regular or irregular. In kids, cardiac output depends mostly on that heart rate. So a low heart rate is a big drop in cardiac output. Bradycardia in children is often a late sign of severe hypoxia, acidosis, or shock. Most common causes, so we have intrinsic causes, are primary causes. These originate from the heart's conduction itself. They're less commonly seen in children, but it could be due to a congenital heart block, sick sinus syndrome, some genetic or structural abnormality, or even a post-cardiac surgery. The key idea is that the problem with these is inside the heart. It is part of the electrical wiring of the heart. Our secondary causes are going to be things outside the heart. They're much more common in children. These are due to conditions outside the conduction that slow the heart down. So hypoxemia, low oxygen level, is the number one cause of bradycardia in peds. Acidosis or severe metabolic disturbances, increased intracranial pressure, hypothermia, medications or toxins like digoxin, beta blockers, calcium channel blockers, or opioids. Remember, little babies are on the floor, and if they're at somebody's house who's on one of these meds and they drop it in the floor, the kid can easily pick it up, put it in his mouth. We can have that vagal stimulation where, they're bearing down, their heart rate drops, their cardiac output drops, and then they pass out. We can have endocrine and metabolic disorders like hypothyroidism or electrolyte imbalances. The idea with this is that your heart's wiring is fine. Something else is slowing the heart down. We need to fix that something to improve that heart rate. So what are we going to see? Clinical manifestations are going to be poor feeding. They're going to tire while they eat. Lethargy, decreased responsiveness, cool, pale, or mottled skin, weak pulses, prolonged capillary refill, low urine output, signs of heart failure or perfusion, poor perfusion. This is dangerous because a low rate means the pump is not moving fast enough. It's not moving enough blood. Bradycardia is a red flag that cardiac arrest could be near if not corrected. Again, diagnosis should be confirmed with an EKG. We might have to do some telemetry monitoring with these kits. So management of dysrhythmias in children, if they are asymptomatic, we're going to monitor. If they're symptomatic with our tachydysrhythmias, we're going to have to use electricity. All right. So your first priority is always going to be airways, breathing, circulations. Give them oxygen, place them on a monitor. Stable child means that we're having adequate perfusion. If they are stable in a tachydysrhythmia, we'd like to try a vagal maneuver. So ice to the face. If they're older, we can have them bear down. We want to capture it on 12-lead EKG if possible. If they're unstable, meaning that we're having signs of poor perfusion, like hypotension, altered level of consciousness. Then we want to use cardioversion, and it needs to be an immediate synchronized cardioversion so that we shock them at the right point of that cardiac cycle and do not throw them into a lethal rhythm. We can use medications. We use adenosine with children. So adenosine rapid IV push is the first line medication. For our Brady dysrhythmias, being that the most common cause is usually hypoxemia, we always treat with oxygen first. We use a stepwise approach where we're using our airway and our oxygen. We can do bag mask ventilation if needed. If the child's heart rate is less than 60 and we have signs of poor perfusion despite oxygen and ventilation, we start CPR. Epinephrine is your first line medication. Atropine is if bradycardia is due to increased vagal tone or a primary AV block. And sometimes we can do pacing, either through the skin or we put in a temporary transvenous pacemaker if we're unresponsive to medication. Your general nursing supportive care for both of these is going to be continuous monitoring with telemetry and making sure we get that EKG. We want to monitor perfusion, so pulses, capillary refill, skin color, urine output, level of consciousness. We want to make sure we're reducing the metabolic demands. Keep this child calm, cluster care, keep them with their parents to reduce separation anxiety. We want to educate caregivers about the signs of poor cardiac perfusion, feeding issues, color changes, lethargy, and diaphoresis. Long term, we may require cardiology follow-up, antiarrhythmic medications, or a surgical pacemaker implantation. So if they're tachy, we can try vagal, we can do adenosine. If they become unstable, we need to do synchronized cardioversion. If they're bradycardic, oxygen first, CPR if heart rate's less than 60 and we're having signs of poor perfusion, we can use epi and atropine, and we can pace if needing. Always, always oxygenation first for bradycardia. Now we're going to move on to our congenital heart defects. So traditionally, congenital heart defects are divided into cyanotic versus acyanotic. This was based on whether the child appeared blue, cyanotic, or pink, acyanotic. So this system was misleading in some clinical practices because some things like pulmonic stenosis, if it's very severe, the child will be cyanotic, but your book teaches us this way, so we're going to mirror our book for our lecture. Our four major groups within this is the acyanotic has an increased pulmonary blood flow to it, or it could have an obstructive blood flow. And then we have our cyanotic lesions, which can either be a decreased pulmonary blood flow or a mixed blood flow. Clinical correlations, a lot of these increased pulmonary blood flows, we're going to talk about a left to right shunt. And what that means is that the left side of the heart has a higher pressure to it. So when we have a hole between our left and right side, the blood moves from the area of high pressure over to the area of low pressure. This gives us signs of heart failure because we're getting too much blood inside the lungs and we're going to have backup of blood onto the right side, which is going to give us that hepatomegaly, edema, and things like that. Our obstructive defects are going to block outflow. So if we have an obstructive defect, it could show signs of left-sided heart failure, right-sided heart failure, and we'll get into all of that. When we're talking about things that have a decreased pulmonary blood flow, we're going to have cyanosis with that. And then our mixed lesions really have variable presentation. So starting with our acyanotic increased pulmonary blood flow. This is going to be our atrial septal defect, our ventricle septal defect, our patent ductus arteriosus, and our atrial ventricle septal defect, also sometimes known as atrial ventricular canal. So, left to right shunt pushes oxygen-rich blood into the right side, and thereby more goes into the lungs and more goes into, backs up into the body. This makes the lungs overloaded and the heart works harder and eventually leads to heart failure if untreated. So our definition is increased pulmonary blood flow defects are congenital heart conditions where blood is shunted from the left side of the heart to the right side of the heart, leading to too much blood going into the lungs. The hemodynamics, because the left side of the heart has that higher pressure, blood flows from the left to the right through an abnormal opening. This increases pulmonary circulation, creating volume overload in the lungs and the right side of the heart. Over time, the heart muscle works harder and the pulmonary congestion interferes with oxygen exchange. Common lesions are atrial septal defect, which is an abnormal opening between the atria, a ventricle septal defect, which is an abnormal opening between the ventricles. Our patent ductus arteriosus is when the ductus arteriosus fails to close after birth, or an atrioventricular septal defect, which is a large hole in the center of the heart involving the atria and the ventricles. Our generalized clinical manifestations for these are going to be tachypnea, increased work with breathing, frequent respiratory infections, tachycardia, heart murmurs, signs of congestive heart failure, poor feeding, sweating with feeds, failure to thrive, poor weight gain. Generally, we're going to be irritable, fatigue. Complications, if untreated, will be heart failure, pulmonary hypertension, growth and development delays. So starting with our atrial septal defect, this is that opening in between the two atriums. So the wall that's between the right and left atrium or your upper chambers of your heart. This allows blood to flow from the higher pressure of the left atrium into the lower pressure of the right. That's that left to right shunt. Extra blood goes into the right atrium and then into the right ventricle and then finally into the pulmonary artery. This leads to increased pulmonary blood flow and volume overload on the right side of the heart. Over time, dilation of the right atrium and the right ventricle puts an increased risk for pulmonary hypertension. If it's a small hole or manifestations, we might be completely asymptomatic. If it's a moderate to large, we're going to have a heart murmur, which will be a systolic ejection murmur, frequent respiratory infections, tachypnea, shortness of breath, poor feeding, failure to thrive, fatigue, and exercise intolerance. Your complications are going to be heart failure if untreated, pulmonary hypertension and arrhythmias, and a risk for stroke. So our management. If it's small, it might spontaneously close within the first few years of life. If it's large, it might require closure with a cardiac catheterization device or a surgical patch. Timing really depends on the symptom and the size. Nursing, we need to monitor our feeding tolerance, our growth, our respiratory status, and teach parents about signs of worsening heart failure. So your simple takeaway, atrial septal defect is a hole between the atrium. Blood flows left to right, sending extra blood into the lungs. Kids may seem fine at first, but can develop poor growth, infections, and heart failure if the hole is large. Ventricular defect. So this is an opening in the ventricle septum, the wall between the right and left ventricles, so the lower chambers of the heart. Blood flows from the higher pressure of the left ventricle into the lower pressure of the right ventricle. This creates a left to right shunt. Extra blood flows from the right ventricle into the pulmonary arteries, then into the lungs. This increases pulmonary blood flow and volume overload in the lungs and the right side of the heart. Over time, the left ventricle becomes overworked because it has to keep pumping the extra volume. Manifestations in a small one might be asymptomatic, might just have only a little heart murmur. In a moderate to large, we're going to have a loud, harsh, hollow stolic murmur at the left sternal border. We're going to have tachypnea, dyspnea, retractions, frequent respiratory infections, poor feeding, diaphoresis with feeds, poor weight gain, failure to thrive, signs of congestive heart failure with hepatomegaly, edema, and fatigue. Complications, pulmonary hypertension, heart failure, and growth delays. Our management. A small one may close spontaneously in the first few years of life. If we have medical management, we're going to be using diuretics, digoxin, and high-calorie feeds to reduce symptoms. If we're doing surgical, we might do a patch or closure device in the cath lab. Nursing, we want to monitor feeding, weight, respiratory effort, and educate parents on signs of worsening heart failure. Key takeaways: VSD is a hole between the ventricles. Extra blood gets pushed into the lung. Small holes may be fine and close on their own. Bigger ones cause problems like breathing troubles, poor feeding, and heart failure. Our PDA. So, patent ductus arteriosus is the normal fetal blood vessel that connects the pulmonary artery to the aorta, allowing the blood to bypass the lungs before birth. Normally, it closes within the first day of life after birth. If it remains open, this is called a patent ductus arteriosus. Because the aorta has a higher pressure than the pulmonary artery, blood flows from the aorta into the pulmonary artery. This creates that left to right shunt, resulting in increased pulmonary blood flow and volume overload of the left atrium and ventricle. Clinical manifestations. Small PDA may be asymptomatic. Moderate to large PDA is going to be characteristic murmur of a continuous machinery noise, like a washing machine. They're going to have tachypnea, dyspnea, retractions, frequent respiratory infections, poor feeding, diaphoresis with feedings, poor weight gain, failure to thrive, signs of congestive heart failure severe, widened pulse pressures, bounding pulses. Complications: pulmonary hypertension from the extra blood flow, heart failure, and then also a risk for endocarditis. Management of your PDA. So we can give in our preterm infants indomethacin or ibuprofen to close the PDA. Diuretics and digoxin can help with symptoms of heart failure. Interventional, we can go through cardiac catheterization and we can coil it or put in a closure device. Key takeaways: your PDA is when the fetal blood vessel between the aorta and the pulmonary artery stays open. Blood goes from the aorta back into the lungs, overriding the heart and the lungs. Small ones may cause no problems. Bigger ones are going to lead to poor growth, breathing problems, and heart failure. Atrioventricular septal defect. An AVSD is a large congenital heart defect involving both the atrial septum and the ventricular septum, along with abnormalities of the atrioventricular valves. So those are going to be the valves between the atrium and the ventricles, so your mitral valve, your tricuspid valve. The pathophysiology: blood moves from higher pressure left side to lower pressure right side. This causes excessive pulmonary blood flow and volume overload in the lungs and the heart. The AV valves often leak, which is regurgitation, which adds to the workload. Over time, right atrium and ventricle enlargement occurs, pulmonary hypertension develops, and the left ventricle overworks to keep up. Clinical manifestation. Symptoms usually appear early in infancy. We have a harsh systolic murmur. We have tachypnea, dyspnea, retractions, poor feedings, sweating with feeds, failure to thrive, poor weight gain, frequent respiratory infections, and signs of congestion heart failure. This is often associated with trisomy 21, which is Down syndrome. Complications, if untreated, are going to be severe heart failure, pulmonary hypertension leading to irreversible damage, and growth and developmental delays due to chronic hypoxemia and a poor energy balance. Management, medical management, initially we're going to be using diuretics, digoxin, high calorie feeds to manage our symptoms. Definitive treatment is going to be a surgical repair, patching the septal defects and reconstructing those valves. Usually it's done within the first 6 to 12 months of life. Ongoing cardiology follow-up will be required for valve function and rhythm monitoring. Nurses need to monitor feeding tolerance, growth, respiratory effort, support families, and educate about early surgery. Your simple takeaways: AVSD is a very big hole in the middle of the heart involving both septums and valves. It causes a major left to right shunting, lung overload, and heart failure in infants. It is strongly linked with Down syndrome and definitely requires surgery. Now we're going to move on to our acyanotic obstructions, to our blood flow from our ventricles. So an obstructive lesions are congenital defects where the blood flow is blocked or narrowed as it leaves the heart. The obstructions make the heart pump harder, which increases pressure before the blockage and reduces blood flow after the blockage. Hemodynamics: the ventricles facing the obstruction must work against the higher afterload. This leads to hypertrophy or thickened heart muscles, which can eventually weaken and cause heart failure. The degree of symptoms depends on how severe the narrowing is. Our common types are corrucation of the aorta, which is a narrowing in the aortic arch, aortic stenosis, which is a narrowing of the aortic valve, and pulmonic stenosis, which is a narrowing of the pulmonary valve or artery. Clinical manifestations. Overall, you're going to see heart failure, which is the pump failure, and a decrease in cardiac output, and we'll discuss these with each disorder. Our complications, if untreated, will be heart failure, hypertension, poor growth, activity intolerance, and even sudden death in severe cases of aortic stenosis. So obstructive lesions are that narrowing that make the heart pump against the blockage. This causes high pressure before the obstruction and low flow after it. If not fixed, it will lead to heart failure. So starting with the corrucation of the aorta, this is a congenital narrowing of the aorta, usually near the ductus arteriosus. The narrowing blocks the blood flow out of the heart to the lower body, creating a pressure difference. The ventricle must pump harder to push blood past the narrowing. So we develop left ventricular hypertrophy. Blood pressure is high before the narrowing in the upper body and low after the narrowing in the lower body. If severe, infants will have systemic circulation beyond the narrowing, may depend on the ductus arteriosus staying open. And this is just an image of the corrucation of the aorta. So this is the top of the aorta, and these stem out to your upper body, and then the aorta comes down and feeds the lower body. So at this intersection where it's tight, that's why the upper body will have bounding pulses and hypertension, and the lower part of the body is getting less blood flow. So the narrowing of the obstruction increases the afterload to the left ventricle. Blood supply is decreased to the abdominal organs and the lower periphery. Left ventricular pressure increases. Aortic pressure is high, proximal. So we'll have bounding pulses in our upper body. Manifestations. Infants with severe narrowing are going to have irritability, poor feeding, tachypnea. They're going to have pale or mottled lower body, weak or absent femoral pulses, and heart failure and shock if the ductus arteriosus closes. Older children will have upper extremity hypertension. They might have headaches, nosebleeds, and dizziness. They'll have strong bounding peripheral pulses in their arms, but weak or absent peripheral and femoral pulses in their legs. They might have leg cramps or pains with activity because we're having reduced blood supply to those lower extremities, which have very large muscles in them, and those large muscles require a lot of blood and oxygen to keep them working. On assessment, we'll see a systolic murmur. Often it's going to be best heard on the back of the left scapular area. Complications, if untreated, are going to be hypertension, heart failure. We can have an aortic rupture, a stroke, or endocarditis. Management. So newborns with a critical corrugation of the aorta, we're going to give them prostaglandin E1 to keep the patent ductus arteriosus open and maintain systemic blood flow until we can get surgery. And I have more about the prostaglandin and the ductus arteriosus on the next slide. Definitive repair, sometimes we can go in and we can do a balloon angioplasty in a cath lab, and it will help open up that narrowed area. Sometimes we have to put a stent in, or we have to do a surgical resection and reconnection. So we just cut out that narrow part and reconnect. As a nurse, we want to make sure that we're always checking our four extremities for blood pressure. We want to assess and compare our upper and lower pulses. And if we have a child who goes in for a balloon angioplasty or a stent, we want to make sure that postoperatively we're monitoring for a reoccurrence of the corrugation. The balloon angioplasty or stenting can fail. So again, corrugation is the narrowing of the aorta. The blood pressure and the pulses are stronger in the arms, but weaker in the legs. Babies can crash if the ductus closes, and older kids often have headaches, nosebleeds, and leg pain. So the ductus arteriosus is the normal shortcut vessel babies have before birth. It usually closes after birth, but in some heart defects, we need that shortcut to stay open so that blood can get to the body. Prostaglandin helps to keep it open because of it relaxes things. So again, if you're asking yourself, what is the ductus arteriosus? In babies before birth, the ductus arteriosus is the normal blood vessel that connects the pulmonary artery to the aorta. This lets blood skip the lungs in the womb since babies get their oxygen from the placenta, not the lungs. What normally happens after birth, as the baby takes the first few breaths, the lungs open up, and then the ductus arteriosus is supposed to close within the first few days of life because now the lungs are oxygenating and doing their work. Why we want to keep it open is in some heart defects, like a critical aortic stenosis or corrugation, or when we get into our acyanotic one, or I'm sorry, when we get into our cyanotic ones, there's a lot of them that the blood is not able to circulate in the heart or get out to the body. So the ductus arteriosus becomes a backup road that lets the blood still get to where it needs to go. If it closes, a baby can go into shock or the child could die. So the prostaglandin E1 is the medication that relaxes the ductus arteriosus muscle and helps it to stay open. So we're giving it to the baby as a temporary detour route until we can do surgery and fix whatever the real blockage is. Now, if we want to close it, Remember, we can close it by giving indomethacin. So indomethacin closes, prostaglandin E1 keeps it open. So now moving on to aortic stenosis. Aortic stenosis is a narrowing of the aortic valve that obstructs blood flow from the left ventricle into the aorta. And then the aorta goes out to the body. The obstruction makes the left ventricle work harder to pump the blood to the body. Your pathophysiology, we have an increased resistance of left ventricular hypertrophy, so we get a thickened muscle. If the ventricle cannot compensate, we're going to have a decreased cardiac output. Severe stenosis can lead to poor systemic perfusion, shock, and sudden death. And this image is just to kind of show you where the aortic valve is and it's narrowed. It's kind of hard to see that it's, narrowed on a slide, but there it is. And again, it's going to alter your hemodynamics. So blood is going to try to flow through the aortic valve and go out to the heart, but it's not going to be able to. So we're going to have increased pressure and hypertrophy in that left ventricle, which is going to cause decreased cardiac output and a decreased blood supply to our coronary arteries and our body. So what are we going to see? Our clinical manifestations. In infants, we're going to have poor feeding, tachypnea, lethargy, signs of heart failure, and weak pulses everywhere. In our older children, we're going to hear a harsh systolic ejection murmur, best on the right upper sternal border, chest pain, dizziness, syncope with exertion, fatigue and exercise intolerance. In our severe cases, we can have risk of sudden collapse with activity. Complications if untreated, left-sided heart failure, arrhythmias, and sudden cardiac death during exercise. Our management. So, prostaglandin may be given to newborns with critical aortic stenosis to keep the ductus arterius open until surgery. Interventions, sometimes we'll do a balloon valvuloplasty in the cath lab to kind of help open that valve up. If that doesn't work, we'll have to do a valve repair or replacement if it's severe or recurrent. Your nursing considerations, we want to monitor for perfusion. So what's our pulses like? What's our capillary refill? What's our cognition? What's our blood pressure? We want to educate families about activity restrictions, especially if we have a child with significant stenosis. We want to teach them warning signs. If the child syncopizes, has chest pain or fatigue, they need to see medical attention. So your key takeaways here, aortic stenosis is a narrowed valve that makes the left ventricle push too hard. Kids may faint, get chest pain, or tire out with activity. Severe cases can be life-threatening and often need balloon dilation or surgical replacement. Pulmonary stenosis. So pulmonary stenosis is a narrowing of the pulmonary valve or an area just below or above. The obstruction creates a blood flow from the right to the left pulmonary artery. The right ventricle is going to have to pump hard against the narrow opening. This leads to right ventricular hypertrophy, which would be that muscle thickening. In severe cases, less blood reaches the lungs and therefore cyanosis can develop. And this is just showing you, the route that it takes, and that in this area would be your pulmonary stenosis, so that right side of the heart would have to pump harder to get it to go through. So your manifestations, if it's a mild case, it might be completely asymptomatic and we might just hear a little murmur. In a moderate severe case, we're going to hear a harsh systolic murmur at the upper left sternal border. We're going to have fatigue and shortness of breath with activity, cyanosis, signs of right-sided heart strain like hepatomegaly, peripheral edema. Those would be late signs. In an infant, poor feeding, tachypnea, and failure to thrive. Complications if untreated, we're going to have progressive right-sided heart failure, cyanosis and hypoxemia, and arrhythmias. Management, if they're mild, we just do monitoring. If it's moderate to severe, we're going to do balloon valvuloplasty to try to open it up. We might do a surgical replacement if balloon dilation is not effective. As a nurse, you want to monitor for oxygenation, perfusion, and feeding tolerance. You want to educate family about signs of worsening obstruction, such as increased cyanosis, poor feeding, and fatigue. So the key takeaways is pulmonary stenosis is a narrowed valve leading from the right ventricle to the lungs. Mild cases may only have a murmur, but severe cases may have a blue baby. They may tire because there's not enough blood reaching the lungs, and your treatment's going to be balloon dilation or surgery. And that's the end of this first lecture. In the next lecture, I'll go over cyanotic congenital heart disease and some medication overviews about digoxin and Lasix.